Perfect, perfect. Great. St. Paul's, can you hear us? Just wave if you can. No? No? Okay. All right. Great. So you know what? We're going to get started because this is the first time that all of us are going to hear this, and this is of interest to all of us as nephrologists. So it's really a great pleasure to introduce Dr. J. Johnston and Kamila Romanowski. They're from BC CDC and the TB Center of Excellence, and Jay is an associate professor at UBC, and Kamila is has got her master's in public health and is working as a TB researcher. And we've had an interesting partnership with BC CDC and BC Renal and BC Transplant for that in order to determine how best to manage a group of people at risk. And so I wanted them to share, or they wanted, and we were excited to share the preliminary results of a Provincial CKD-TB Screening Program. So without further ado, and there are 7 on the line, and there are a number of people in other locations, and this is truly of interest to the entire province. And people have been asking me what's happening without that screening that we're doing, so I thought it was a great opportunity. So thanks for coming.
Thanks for having us. I presented here a few years ago, and so I hope to present some answers to some of the questions that I posed a couple of years ago, talk a little bit about outside research we're doing, and then talk mostly about the Provincial TB Screening Program, and then hopefully we'll leave about 10 minutes for questions at the end. Kamila will specifically be presenting on the impact of the program, which I think will be mostly of interest to people. So she'll be presenting the interesting part. So first of all, no conflicts of interest to declare. I don't think that was up there, but instead of putting that at the end, I think this is really important to acknowledge at the start that there's people across the province have been working on this program. And so I'd like to thank everyone in this room, thank everyone at distributed sites, everyone across the province who's working in dialysis units, who's drawing blood, filling out the forms, chasing down that chest x-ray, redoing the chest x-ray, getting another IGRA blood draw for the indeterminate. I recognize that this is a lot of work, but I think that we're showing that this is impactful. But I do want to thank everybody up front for all their hard work, and specifically people who are working at Promise and who are sending the data to us. I know that's also really hard, but it's actually really important to have this data. And really, we're one of the only places in the world, if not the only place in the world, that can do this with the databases we have. And I think we need to acknowledge how important these databases are for what we do. Also, people at the BC CDC who have also put in extra work on this. So, yeah, I work in TB, no conflicts of interest. So just to talk a little bit about the global NTB strategy and why we're doing this in part, is that the global NTB strategy is a new strategy, relatively speaking, for TB, came out in 2015, looking to eliminate TB globally. And in low-incidence countries, that is defined as less than 1 per million. And we're trying to do that fairly rapidly, ideally by 2035, if not by 2050. In countries of low TB incidence, this is going to be a challenge, because right now we're around 50 per 100,000 in British Columbia and in Canada. So we are a long way away from doing that. So we're going to have to treat and prevent somehow 49 of those 50 people who are getting TB in the province to get us to TB elimination. This has recently become quite important because TB is the global infectious disease killer. It kills more people than HIV. And so the United Nations actually had a high-level meeting with heads of state in September 2019 for the first time, looking to make TB a global priority, much like HIV was made a global priority in the late 90s. TB has always lagged in terms of, for whatever reason, in terms of resources. There's a lot of historical reasons for that, but we're seeing the things turn now, and so we need to start, in turn, meeting our requirements for the NTB strategy, and that includes more aggressive screening. So this is just some very basic modeling. I'm not going to dwell too much on this, but basically showing that if we just treat active TB globally, we're not going to get anywhere in terms of elimination. Globally, if we start scaling up latent TB elimination, then we can actually probably get to, or latent TB therapy, we can probably get to TB elimination globally. Why is this important for you? The reason why I think this is important for you is that that means that we're going to start treating latent TB elsewhere in the world besides Canada, United States, Western Europe, New Zealand, and Australia. We're going to start treating TB in high-incidence regions. For example, India has 2 million TB cases a year, accounting for close to 20% of the world's total TB. There are a lot of people with chronic kidney disease in India, so we're going to have to start designing protocols to treat people in India for tuberculosis. So this is going to become a global TB thing, and I'm seeing our province as a proof of principle for the rest of the world to follow. So how are we doing in terms of TB elimination? Well, this is some modeling work we did with our databases here, and basically what it's showing is that with our current screening strategy, this is where we are in British Columbia. If we increase the groups that we screen with, and so this actually would be the first group where we screen chronic kidney disease, transplant patients, and people with HIV, essentially. That's how far we get towards TB elimination. The further we go in terms of populations to screen, and this gets into screening people with just simply demographic predictors, such as being born in a high-incidence country, the closer we get to a TB elimination. So again, why is this important? I think it's important because this CKD-TB screening program is a very small part and a proof of principle of a much larger campaign to screen people for latent TB. But we need to get our ducks in a row, and we need to figure out how to do it and see if it actually has epidemiological impact before we start rolling it out to other groups, such as people with diabetes, people with pre-end stage kidney disease. So we have a long way to go still, but again, this is a really important first step. So I think everyone here knows that there's a link between chronic kidney disease and TB. If not, you knew from the title. This is the first article that we can find identifying tuberculosis in dialyzed patients from 1974, showing that people who are dialyzed are at increased risk of TB. Subsequently, there has been quite a bit of literature on this. And so we asked the question, what is the risk of TB in end-stage kidney disease? I think I've shown this data before, but we did perform a systematic review back in 2015, showing that there's a substantial increase in risk of people who are on dialysis of developing TB. So this is a systematic review showing that in unadjusted rates, it's about 10 times the risk compared to an age and sex and comorbid adjusted population. If you look in BC, this is an article from BC showing that in BC, people with end-stage kidney disease on dialysis have 25 times the rate compared with the control population. So substantially increased. That's about the same rate as people with HIV. So this is a really high-risk group that I don't think has had enough attention. In terms of other end-stage kidney disease groups, we also looked at transplant recipients in the same systematic review, showing that similarly, they have very high TB risk, at about 8 to 10 times the risk. And so these are groups that we absolutely, in my mind, must screen and prevent TB in, because it's just, for me, it's the same as HIV in terms of risk. So what about the second question we asked is, what about the risk of TB in pre-dialysis chronic kidney disease? So people start dialysis, but is that the time that your risk for TB starts, or does it start long before that? I think nephrologists have told me in passing that they notice that there's increases in infections earlier than dialysis, and there's a little bit of literature to show that there's increase in pneumonias before you have end-stage kidney disease. But when does that start? And so in that systematic review, we found no articles addressing this issue at all. And so we hypothesized, and this is actually a paper that Kamila wrote a few years ago, that there's really a few different ways that risk could increase in dialysis. So you could have this sudden increase in risk of TB at end-stage kidney disease, or you could have a gradual increase. And so we went out looking for data sets to actually investigate this. And I ran into a colleague who's in Taiwan who has access to their large database in chronic kidney disease. And so this is going to be coming out soon, showing that as your GFR declines, so it's going, in this case, it's going right to left as your GFR declines, your adjusted hazard ratio for TB gradually goes up. So it looks like there's no specific cutoff where, oh, okay, at a GFR of this, we should start screening. It looks like it's this continuum. The problem is, I think, as everyone in this room knows, that the populations here are much larger than the populations on dialysis, and they're much harder to identify. You don't necessarily get referred those patients early on. You might be referred much later in the person's decline in chronic kidney disease. And so dialysis seems like an easy place to identify, but we must keep in mind that actually risk increases before you actually enter into dialysis. It actually increases gradually over, the GFR 30, 15, 10, etc. So in summary, people in dialysis have about a 10-fold risk. In BC, it looks like it's a 25-fold risk based on that study and a separate sort of study that we've performed. It looks like transplant recipients have an 8-fold risk. As your GFR declines, your TB risk increases, but there's no specific threshold for screening. We've done a little bit of cost work on this, which I haven't shown today just because it's a little bit complicated, but there is definitely cost effectiveness of screening people in different high-risk populations earlier in dialysis, but it's much harder to implement. For now, though, we believe that at least screening in dialysis is a good first step. Whether or not we should be screening before dialysis is, I think, maybe a conversation we can have at a later date, but it involves much more money, much larger populations. So who cares? Who cares about screening? Is screening useful? Well, we think screening is useful for a few reasons. One, we think, and this is a very fundamental thing, is that it detects active TB early. So I think everybody has seen a person with active TB in a dialysis unit. What happens is that person is surrounded by other immune-compromised people, and they are likely coughing, and they could be infectious or not infectious, and it takes a while for them to be diagnosed. And so that person may be sitting in a dialysis unit for several weeks to a month to 2 months before they actually are diagnosed with TB. And at that point, all the people around them will be at risk for TB, and they could be potentially infected. And so what we found ourselves doing in TB was about once every 6 months, there'd be a dialysis case identified, and we would go and do contact screening in the dialysis unit. And then 6 months later, we get another TB case, and we go back, and all these people were being screened and rescreened and rescreened. So just from a resources point of view, it seemed like a big waste of money. It also puts people through routine screening over and over and over, and puts people at risk of TB. The other thing is that we know that morbidity and mortality related to TB are related to how early you're diagnosed. So the later you're diagnosed, the higher the mortality and morbidity. We also know that people on dialysis have nonspecific symptoms that could be attributed to dialysis, it could be attributed to TB, we don't know. And so it takes a little bit longer for those people to be diagnosed. And so we're trying to limit the morbidity and mortality in the dialysis population by getting to them early and screening them with an IGRA and then a chest X-ray. So that's one fundamental reason. From an epidemiological standpoint, which is really what I've been talking about today, is that detecting and treating latent TB can prevent active TB. And so if we can get them early, before they actually develop active TB, give them preventative medications, we can prevent the TB from occurring. And that's really the fundamental goal in terms of impact. That's much easier to measure than early detection. So what is the BC Chronic Kidney Disease Screening Program? Well, we aim to systematically screen all people who are on dialysis, who initiate dialysis. So the moment you initiate dialysis, you go through the screening program, is the idea, if you live in BC. So you get a TB risk questionnaire, which is basically looking at risk factors, which is a huge component of this because we know that somebody who was exposed to TB or lived in a very high incidence network or high incidence community is at much higher risk than somebody who was not. And so it's really to give us our pre-test probability. That's what the TB risk questionnaire does. It also tells if they've been treated before, which is actually really important. You get a chest X-ray performed on everybody, which is already done, is my understanding, as part of the routine dialysis workup. You usually do lines. And then you get an interferon gamma release assay. And so those are the three components, and all three are necessary, and I'll talk a little bit about that later. So what is an IGRA? They've been around now for 10 to 15 years. They're commercial products. So they are essentially a blood test that is like the tuberculin skin test. It's an immune assay. So the tuberculin skin test used to be you inject some protein, see if you react to it in your arm. What the IGRA is a series of proteins specific to TB, and it's notably not in the BCG vaccine, so it's specific to TB, and it measures an immune assay. It measures like your immune cells released to these antigens. It has positive and negative controls, so we can have indeterminants if, for example, it doesn't react, which is a sign of energy, or it can be positive or it can be negative. The positive is, this has been a cutoff that has been somewhat arbitrarily defined, meaning 0.35 is the positive in the quantiferon. Whether or not that should be the true positive, we don't know because there's not enough epidemiological evidence to support what a positive and negative. So keep that in mind when we're interpreting these tests, that this is not a perfect test. What's the advantage of the IGRA? I think there are multiple advantages to the IGRA. One, it's specific for TB. It doesn't cross-react with BCG. It appears to be slightly more sensitive in people on dialysis likely due to immune suppression and related energy. And the third thing I think is really important is that actually it's recorded in our data systems. So when you are going through this person's Care Connect file, you can actually find it and say, oh, this person's had an IGRA, whereas TST is not recorded. So it's not a magical test. It's not, infinitely better than the tuberculin skin test, but it provides these incremental advantages, which I think are really important for this program in particular. So how we approach the evaluation of the TB screening program, we did three things collectively. Representatives from the Renal Agency, from BC CDC Labs, and BC CKD-TB Services got together and said, how do we want to evaluate this program that we've been rolling out? And so this was planned from the start, essentially, planned prospectively, was how do we measure the epidemiological impact? We want to measure that and see if it's actually impacting rates of TB in the population, which Kamila will soon talk about. We want to know if it's safe. Is this a safe program? Sure, we're treating all these people with latent TB therapy, but is it actually safe to do that? And then what is the level of screening program uptake? So, is it impactful? Are we harming or helping patients? And are we actually doing it province-wide? All of these, I think, are important questions to answer. And if we fall down on one of these questions, then we have to ask, why are we doing this? So that's what Kamila is going to talk about. First is the epidemiological impact of screening.
This is considerably more nerve-wracking than analyzing data in front of my computer, so bear with me if I stumble over my words. So as Jay mentioned, my goal in this portion of the analysis was to evaluate the epidemiological impact of the screening program. Specifically, we wanted to compare what was the active TB risk in people screened using an IGRA to the active TB risk in people not screened during the same time period. We defined anybody as being screened as if they had received an IGRA within 365 days of dialysis initiation. So anytime I say screened, I mean IGRA within 1 year, regardless of any previous TST they may have had. And our outcome of interest was the first episode of any form of active TB notified to the BC CKD-TB registry. And this could either be microbiologically confirmed or clinically diagnosed active TB. So to create our study cohort, from PROMISE, we extracted information on everybody who initiated dialysis from the 1st of January 2012 to the 31st of May 2017. From that group, we excluded anybody who received less than 90 days of dialysis. We also excluded anybody who didn't have a PHN, since we wouldn't be able to link their data. Removed anyone who was less than 18 years of age, and then we had to remove one person due to data discrepancy. This left about just under 5,000 people in our group. We then linked in the TB data from the BC CKD-TB registry, and this led us to exclude an additional 104 people who had a prior history of active TB or who had a history of latent TB treatment. And this is because they wouldn't actually be eligible to receive an IGRA. And then we linked in our final data set, which is the IGRA data from the BC CDC Public Health Labs. And this let us separate our cohort into 4 groups. So the first group was everybody who was screened or received an IGRA within that 1 year time frame. We had about 1,790 people in that group. Then our second group were people who had received no screening, so no history of an IGRA or no recorded TST in our TB database. And then the third and fourth groups were people who had who had received an IGRA, but it was outside of that 1 year screening window. And then the last group were people who had only had a history of a reported TST. So those last 2 groups were excluded from our primary analysis, but included in subsequent sensitivity analyses. And then those first 2 groups are the ones that made up our primary study population. So if we look at the baseline characteristics of our study population, we could see that people who were screened were more likely to be younger, they were more likely to be of a non-Caucasian ethnicity, and they were also more likely to have a renal transplant post-dialysis initiation. People screened were also less likely to have an immune-suppressing comorbid condition at the time of dialysis initiation, and all of this data was extracted from PROMISE. So then when we looked at IGRA screening results, we saw in the people that were screened, the median time frame between dialysis initiation and their first IGRA was 16 days. And the majority of people actually had a negative IGRA. One thing that I think is really important to highlight is that we had really low rates of indeterminate IGRAs in this group. They accounted for about 2% of our IGRA results. So now that you have all of this background information, I go back to the main question of, well, what was the epidemiological impact of this screening program? So during follow-up, we had 17 people who were diagnosed with active TB. 11 of them received no screening, and 6 of them were from the screen group. We then used Cox proportional hazard regression models to determine the hazard ratio between being screened and developing active TB. And in an adjusted model, which we adjusted for baseline variables that were unequally distributed, so age, ethnicity, immune suppressing comorbid condition, and renal transplant, we saw a hazard ratio of 0.3 with confidence intervals between 0.1 and 0.8. Basically, what this meant is that screening was significantly associated with a 70% reduction in the likelihood of developing active TB when we compared it to people who weren't screened, which we thought was a pretty significant finding. When we looked at the cumulative hazard graphs of these, we could see that the majority of active TB in both groups was diagnosed within the first 500 days. So the red line at the top, I realize this might be a little bit hard to see. The red line at the top are people who received no screening. The blue line at the bottom is people who were screened. And anytime you see a blip, it basically indicates an active TB diagnosis. So you can see that the majority happened within the first 500 days. And when we looked at the median time frame, we actually saw that in both groups, the median time between between dialysis start and active TB diagnosis was 300 days. So most of the active TB was occurring within that first year of starting dialysis. So as I mentioned, we had 17 people who were diagnosed with active TB, 11 who were not screened and 6 who were screened. They were predominantly male. Again, a large proportion had a non-Caucasian ethnicity. Slightly more than half were diabetic at dialysis initiation. And interestingly, of the 6 people that were screened, 4 had a negative IGRA on screening and then went on to develop active TB within that year. The 2 people who were screened positive were offered latent TB treatment but declined. So then we thought, well, we've seen this impact of the screening program, but then what happens if we look at the impact of screening and treatment? So when we looked at people who were screened, we saw that 152 people went on to start LTBI treatment. And the median duration between dialysis start and active TB treatment was 195 days. When we looked at people who weren't screened, there was only one person who started LTBI treatment, and this person started treatment post-renal transplant because the donor was from a high-incidence country and had an abnormal chest X-ray. So what we did is we split our group again into our cohort into 2 groups. So our first group was people who received no screening, and then our second group, instead of just being screened, it was people who were screened and treated. And when we looked at the cumulative hazard graph of that, we saw that people who were screened and treated, out of the people who were screened and treated, no one went on to develop active TB. So that's the bottom line in blue again. And you can see no blips, no active TB. So basically just a quick summary, we saw that systematic screening of people initiating dialysis was associated with a 70% reduction in the likelihood of developing active TB. And we also saw that screening increased the uptake of LTBI treatment, and no active TB was found in the people that were treated for LTBI. Before I hand it back over to Jay, I just also want to, again, mention a quick thank you to everybody involved in the collection, maintenance, and analysis of these data sets. This is actually the first study looking at the population impact of LTBI screening in dialysis patients, and it's because of these data sets, these really well-maintained data sets that we have in BC, that we're able to do this analysis. And I think it's really great that we're able to do these collaborative projects that produce these quite meaningful and impactful results. So again, thank you. And now I hand it back to Jay.
now the bad news. How safe is the screening program? So sure, we're treating all these people with latent TB based on the screening program, and yes, nobody who gets latent TB treatment has developed active TB. Great, but the question is are we harming the people with the latent TB treatment? So are we just trading one disease for another? And so that, I think there's a lot of people in the renal community and in the general practice community who are raising eyebrows looking at us saying, you guys are treating some pretty old people with latent TB therapy. I remember in med school that we should be not treating people over the age of 35, and I can see that you're treating 70-year-olds. So is this a safe strategy? And I think it's a very reasonable question. And so for this part of the study, we looked at the proportion of people who completed a course of latent TB treatment. So how many, that's a good marker of safety. If most people are completing therapy, that's a good marker. The proportion of people who had actually serious adverse events, and whether or not latent TB treatment outcomes changed according to a more aggressive strategy, which has been implemented in the last 5 years compared to the years prior. So from 2001 onward, we had this sort of, we'll treat somebody with latent TB if we think about it. Let's make sure that it's safe. And then from 2012 onward, we've been much more aggressive in treating latent TB. And I know Tori Cook's in the back, and I've personally shamed her once for not starting latent TB treatment on a dialysis patient. And so it is a bit of a culture shift for us, and we got to make sure that it's safe. So what we did for this was we looked at latent TB treatment outcomes. We took 378 dialysis patients on latent TB therapy from 2001 to 2017. And sorry, this data is a little bit old, but these data linkages take time. We had the primary latent TB therapy cohort, which is the more aggressive cohort, the people starting dialysis 2012 to 2017. So we treated more people in that group compared to a historic cohort, which presumably was people a little more highly selected. And so this is what the group looks like. So you can see that predominantly male, about 2/3 are male, predominantly older at 66 and 62. This is not a surprise to people who treat dialysis patients. We can also see that even in this historic cohort, a lot of people were getting IGRAs. And I think this is a legacy of the St. Paul's and VGH screening programs, which were rolled out a little bit earlier than the rest of the provincial screening program. But also, I think it's really important to note that 20% of people were starting on latent TB therapy based on clinical evaluation alone. And what that means is based on your chest x-ray and your history. And so just alluding to that chest x-ray, I think it's really important because it's really changing therapy. Almost everybody got isoniazid, even though now really rifampin is the standard of latent TB treatment, 4 months of rifampin. There's just so many drug interactions involved with rifampin with dialysis patients that it's very difficult to execute that. So we're still using isoniazid in most people. To our credit, we are starting people earlier on latent TB therapy. I still don't think it's enough. We noticed that it was a 300-day lag to initiation of therapy. I think we can do a lot better than that. Or, sorry, was it 187 or something?
That was done in years, which I
yeah.
would apologize for.
Yeah.
It should all be the same.
Yeah, so almost a year, though. This is the good news. So very high rates of treatment completion. So 75% of people completed therapy. This is compared to, in the literature for latent TB therapy, about 50% of people complete therapy. So this is much better than historic literature. Even in randomized trials, outcomes are around 75 to 80% of complete therapy in healthy RCT populations. So this is actually quite a good treatment outcome for treatment completed. That also includes a large group of people who are ongoing. So it's more like 80% of people have completed latent TB therapy. In the historic cohort, very similar, except they have a little bit higher treatment completion rate, probably because of the ongoing treatment rate is less, obviously, because it's historic. And so about the same treatment outcomes in this more aggressive compared to the more highly selected populations, which is good news. This is the bad news. I don't want everyone to freak out when they see this. So serious adverse events, 23% and 19% of people had serious adverse events. However, serious adverse event was defined as a medication switch at any point. So, for example, if we gave somebody isoniazid, and I can tell you we do this all the time, gave somebody isoniazid and they got slightly nauseated, we'd say, oh, you know what? Let's try you on rifampin. Let's deal with that medication interaction, try on rifampin. And that is the vast majority of people. We have a very high rate of medication switch everywhere. Our colleagues, when we do multinational randomized trials in this area, always laugh at us because our serious adverse event rate is extraordinarily high compared to everyone else because we switch a lot just to get people through therapy. So I am reassured by this. Specifically, I'm reassured by the hospitalization related to latent TB therapy. One person in the primary cohort and one person in the historic cohort, and that person was hospitalized for depression, if people want to know. And so these are not highly hepatotoxic people who come in with ASTs of 4,000 who are hospitalized for liver failure. These are people who generally tolerate therapy quite well, and probably to the credit of the dialysis units, because they're observed so closely, that we can catch those adverse events very, very, very quickly and switch them over to another therapy if we need to. So yes, high rates of serious adverse events, but extraordinarily low rates of hospitalization. This is lower than just general population. And I am personally reassured by this. The only thing I would say is that there is some hepatotoxicity, but again, this matches when you look at randomized trials, it's about 5% hepatotoxicity in RCTs, and this is not severe hepatotoxicity. This is reversible. You stop the medication, it goes away. So I believe it's safe in dialysis. We can talk more about the data if you're interested. And this is despite the presence of very significant comorbidities, multiple medications. This is very similar data in terms of hospitalizations to the general population, specifically a cohort in Quebec. And this is a small sample size, but I believe that we're dealing with a safe treatment here. So I think we're getting people through therapy safely. So we have what we think is an effective program. We have what we think is a safe program, but is it a program that people are using is the next question. And so what is the level of screening program uptake? So our goal here is just to look at the regional health authorities and look at what sort of uptake we have across each of the health authorities. We didn't parse further than health authority, but we can if you want. So you can see that Vancouver Coastal Health has a much higher screening uptake. Keep in mind that Vancouver Coastal Health was doing this for about 3 or 4 years prior to anywhere else in the province. And keep in mind also that this is 2016 data due to some data delivery issues in terms of connecting the two. But what we can see is that all the health authorities have increased this since 2015. 2016, there was a significant ramp up. So I would expect that we are over 80% in all health authorities, but I don't know that for sure. There was a little bit of a lag in Fraser Health, which hopefully has been corrected by now. And when we do our next data linkage, we should be able to see that. But I think there has been enthusiastic uptake across the province. And kudos to everyone who's done this in all the dialysis units. Also kudos to the labs who's had to train all the different hospitals around the province to actually perform IGRAs, which is not an insignificant task. And thank you from the TB program, because this has actually allowed us to roll out IGRAs in other hospitals where otherwise it wouldn't have been rolled out. So this is actually really important for rolling out provincial TB screening. So in terms of evaluation, what's the epidemiological impact? I think we have a statistically significant result. We think it is impactful, especially if we can get people on the therapy. We think it's a safe screening program, recognizing that a lot of people switch medications and it takes a lot of work to get them through, but with intensive monitoring, we can get people through. And we think that the screening uptake is good. So we think so far that this TB screening program has been quite successful. So in terms of the next steps, and this is where we can get into some of the details, can we further refine the program? So there's no point in rolling out this program and never thinking about it again, saying, oh, we've got our impact, we've got our safety. Okay, that's it, let's roll it out. We should be constantly coming back, and this should be iterative and modifying it, changing it to adapt to the needs of the population. So I think one of the questions probably people in this room are asking is the chest x-ray really necessary? Because I know that you get a lot of vague chest x-ray reports that say, can't rule out TB, and then you have to repeat the x-ray, and you get mad at me because my name's at the bottom. I think it is necessary, unfortunately. We can talk about how to do the chest x-ray reports, but the problem is that, as you can see, there were 4 people who developed active TB who had a negative IGRA. And so sometimes those people can be picked up on chest x-rays, and in this case they were. So there was a person who had a negative, I went through these cases, person with a negative IGRA had diffuse opacifications on the chest x-ray, which prompted a TB workup. So the chest x-ray can pick up active TB early, especially when you have a negative IGRA. Number 2, we note that 18% of people who went on to latent TB therapy went on due to a clinical reason. And I can tell you almost always that clinical reason is you have scarring compatible with old TB. And so despite the IGRA is not a perfect test, its sensitivity is not optimal. And so I think we need another test to corroborate findings and make sure specifically that we identify people with active TB. Again, I'm happy to talk about that later. Can we exclude populations from screening? This is an important question. So, for example, can we, Canadian-born populations, generally speaking, are at lower risk for TB. Can we exclude those populations? It turns out that about a quarter of the people who had the positive IGRAs were Canadian-born. And so, and anecdotally, I've seen several Canadian-born patients, post-renal transplant and on dialysis, who have developed active TB. And so right now, with the current data we have and the current outcomes we have, I don't think we can do that, recognizing that the Canadian-born population is at substantially lower risk than people who are born in high-incidence areas. But we'll have to figure out a better algorithm. On the flip side, is it worth doing? So is it worth having a nurse go through a checklist and saying, okay, this person is born in this country, what is their TB incidence? Okay, yes, we screen them. That's a more work for the person drawing the blood to do, as opposed to just drawing serology for hepatitis, drawing an IGRA, et cetera, et cetera. We can debate that logistically, and I'm happy to, but I think for now, I would propose that we continue with screening all populations, partially because a quarter of people were Canadian-born, but also because I think logistically it'd be very hard to define who to screen and who not to screen. Can we shorten the time? So we know that it was a median of 16 days to get the IGRA result from dialysis. I think a lot of that is just actually because they batch the IGRAs. They send it to the lab waits to get enough and then runs it once a week. So I don't think we'll be able to reduce the time from dialysis to IGRA. However, we can certainly decrease the time from IGRA to a treatment initiation start. So if it was an average of 300 days to active TB and it was 0.7, so about 180-something days, 192 days to treatment initiation start, certainly we're beating the average time to active TB, but we should reduce that to hopefully less than 30 days. I think that should be our goal. I think it's an ambitious goal to get people into the clinic and start them on therapy, but we know that people are at highest risk the first year, and so we should get them on therapy as soon as possible. We are able to do this with contact tracing. In childhood contacts of active TB, we can get people in the clinic right away. And I think we should start applying the same threshold for people with dialysis and get them in the clinic right away and communicate that to the dialysis units that we need to see them right away. So that's really on us at the BC CDC to do. We've had some struggles with our EMR, but we are getting through them. And hopefully, once our EMR improves a little bit, we'll be able to get more people in the clinic and see people in a more rapid way. And that's one of the barriers right now, unfortunately. And how do we improve communication? So, recently I wasn't able to attend it, but there's a meeting where people had listed a few different things where our communication has been suboptimal, specifically vague chest X-ray reports. I know that exists. And people arrive to the dialysis unit on isoniazid therapy. And so we need to improve from the BC CDC our communication style so you can know if a person's at risk for TB, if they're on TB therapy, and really what to do with that chest X-ray report. Do you really need to repeat the X-ray, or can you just observe them? And so we can work on those things to improve this protocol, because I think this needs constant monitoring for improvement to make sure that we're doing the best we can do. For us, you may not care about this as much as I do, but one of the keys to TB elimination in the absence of a vaccine is scaling up latent TB screening and treatment. Without that, we're never going to eliminate TB. And so I think we can use this as proof positive that you can identify people with a comorbidity and scale up screening systematically across province, Canada, internationally, whatever, to really improve TB elimination. Because without these sort of mass screening programs, we are never going to get there, unfortunately. And right now, we really only screen people who are contacts and people on dialysis. We don't systematically screen people on immune-suppressive medications, unfortunately. We're getting there. We don't systematically screen people on transplant. We're getting there. But I think this is a really good proof of principle for the rest of the provincial screening programs. And that's it. Thanks very much for listening, and we're happy to take any questions, criticisms, comments. Or it was a perfect presentation.
Thanks, Jay. That was a great talk. What are your resources that you have access to at the BC CDC to help coordinate this? And I ask this because I assume something like contact tracing is probably recognized to be quite important through BC CDC. But if you're trying to reduce that time from IGRA to latent TB treatment down to 30 days when it's existing currently at around 6 months. What sort of logistical infrastructure is available at the BC CDC and support through the health environment there to sort of implement this program?
So, I mean, in terms of logistic infrastructure for data, you're looking at it. So in terms of being able to monitor and evaluate how well we're doing, Kamila spent a lot of time linking this data. It takes a while to do, unfortunately. In terms of using public health infrastructure, we do have a very good network of what we call our virtual clinic. So we have a clinic. We have 2 clinics in the Lower Mainland. We have one in Vancouver, one in New Westminster, both of which treat latent TB and TB full-time. So they run 5 days a week, patients in the morning, patients in the afternoon, for latent TB screening, treatment, active TB, running all the time. And so we can use, in the Lower Mainland, we can just send patients there, and we should be able to get them in earlier for latent TB treatment. For the rest of the province, we have what's called the virtual clinic, who are nurses and physicians who work at the BC CDC, including myself and Tori, who basically get screening forms. They come in, faxed in, we go over everything, we make our recommendations, including treatment, and we send the medications out to nursing stations, public health nursing stations, or to the dialysis units, depending on the patient's needs. And so we have a pretty good infrastructure for initiating latent TB therapy. Unfortunately, it just is not quite as responsive and as speedy as we want. We want to be able to get people in the clinic faster, but unfortunately our clinics are just really clogged up right now. And so what we need to do is better protocolize lower-risk people and improve getting high-risk people into clinic. Does that answer your question, Sean? I'm not sure if that, yeah.
Jay, thank you for your presentation. I'm just wondering if you are planning on standardizing actually reporting coming from CDC, because we have reports ranging from very clear recommendations to literally poetry that is very difficult to interpret.
So that's on the virtual clinic physicians and me. So we have standardized reporting, and Tori has spent a lot of time developing these protocols for the province and getting us all to chip in and come up with the best report. To be honest, some of the complaints around our reporting is due to the standardized reports, because it says we have screened and they're at low risk, and the person's like, well, what does this mean, right? And so we have to improve our standardized reports to start with. In terms of the poetry, I agree. We have a meeting, we have a monthly meeting with our physicians who go over these reports, and different physician, different interpretation, unfortunately. The other thing is that there is subtleties to this that may not be apparent to other people. And when we're going over the report, you may see 2 seemingly similar patients saying, well, why is this person recommended this and why is this one recommended this? It may be physician variance, but it also may be subtleties in the difference in the chest x-ray, of the IGRA result, of the exposure history. And so there has to be some variation for sure, but I think we can be much tighter in our reports, like specifically giving instructions saying, you do not need to repeat the x-ray unless this happens. This person does not need further screening, etc. So we're aware of this and we're working on it, and apologies to all the people who've been running around trying to read the tea leaves. I understand.
Specifically concerned about reports suggesting testing those people for AFB, actually obtaining sputum specimens for AFB, and we don't know how to interpret this. When you have a patient with a dialysis unit and we are receiving recommendations like that, we have to take it very seriously. Is this patient truly actually potentially active? We have to isolate those patients. So this is something that needs to be communicated very clearly.
Yeah, and I think that's specifically one thing we can do is I think in our hedges, we say we don't want to say this person has 0 risk of TB, because we know that nothing is 100% or 0% in medicine. But at the same time, we probably need to have a much more substantial risk to recommend AFB testing, or at least say consider AFB testing in the future if new symptoms evolve or whatever. What we were trying to communicate is that there's a lot of delays in diagnosis in TB because people don't keep it on their radar. So we want to keep TB on people's radar, especially high-risk people, but we don't want them necessarily to run around and trying to get multiple sputums. That's totally unreasonable, I agree. So again, we can work on tightening up our dictations and maybe in concert with nephrologists to say, what do you need? And we can actually provide that interpretation for you, because every single x-ray in dialysis patients has a problem. It either has pleural effusions or fluid overload or whatever. And it's really difficult for us to interpret that, right? And so
but I
we
think
try
also
our
the
best.
important thing that I think that Jacek's asking is when you say that, and that leads to isolation and panic and craziness in the dialysis unit, if you don't really mean that, then say it in a way, and that might be a conversation as opposed to that for dialysis patients. And maybe it's worth like to sit down with the dialysis group and say what would be meaningful and helpful in terms of directing care that should be in the report. And it might be a little program of work that we want to do.
I totally agree, and I think maybe the other thing, and we do this for our active TB cases. We make explicit recommendations on isolation. Say this patient needs to be isolated for at least this long until you see this. So we could do that for these. We recommend a repeat X-ray or we recommend AFB, but we do not recommend isolation in this patient. We think this patient's at low risk.
Sorry.
Yeah. Yeah. Yeah.
Someone who's on the WebEx who can't do the audio. So it's John Antonson and Gayleen in Victoria. So if CKD is the risk and not dialysis, and if early identification treatment are important, shouldn't we move upstream and screen in the CKD clinic?
Great question. Yes. So you would know the data better than I would, but my understanding last time we checked was that there were over 100,000 people who would meet the criteria for chronic kidney disease.
13,000 people registered in the CKD programs, of which, if you were looking at the most high risk, which would be the low, I mean, yes, it's continuous from the data that we just saw, but if we actually took the highest risk, like the lowest GFR bracket, like below 20 mils per minute, I don't think it's 100,000. I think it's probably whatever denominator is. So it's not a massive population. It's much bigger than the dialysis population for sure.
And I think that's the problem, is that I agree. I would love to. We're having a hard time, to be frank, we're having a hard time getting resources to screen transplant patients, and that should be a no-brainer. IGRAs cost about $100. All of the associated testing, the chest x-rays, the physician and nursing time, the administration time to get all these screening packages together takes a long time. And so it sounds like, oh, it's just $100 a person, but it's actually several $100 when you actually add it all up. And so each person we screen costs $700, and we're a TB program, and we are underfunded. And so I would love to go upstream screening. I think our priorities right now are tighten up dialysis, make sure it's screened as best possible, make sure people get on latent TB therapy, make sure transplant patients are screened. I think it's ridiculous that we give somebody else's organ and then we're not screening. I mean, that's unconscionable in my mind.
I mean, they get screened pre-transplant,
but there's
to be on the list, but post they don't.
Yeah, and there's no systematic funding for screening. We are doing it kind of under the cover of darkness because we all want to, but there's no specific funding envelope.
But the business case must be able to be made. I mean, we've talked about this
before. We have presented a business case and it's not been funded.
Okay, so we'll work on that.
Sorry, Tori has to say something.
Yeah, no, I was just going to comment on that. Like, I think as far as I know, we were funded for 5 years, right? I think initially for the CKD program, and I think that's up. And we've put in a new financial ask to continue with the program that clearly is functional and working and having impact, and added dollars to that for solid organ transplant, leukemia, and BMT, and haven't heard a thing. And so right now the IGRA testing, the money for it is coming from like the West Nile budget, apparently. And in some ways, we don't care. We're going to continue to do testing, but it's quite, the situation is quite fragile. And I would say from a resource perspective, initially, when we started the program, there was some sort of administrative money that came in and a little bit of extra doctor money that's come in. But this is a huge amount of work that comes through the clinic, and we are taking money to hire we have another extra FTE physician working, not just to do dialysis, but to do a lot of other things that actually isn't secure either. So I think for us, from a latent TB perspective, if we really want to make an impact, like from a provincial program perspective, we have to really think about how we're going to work the clinics and increase our clinic times, because we're not going to get anywhere. The other thing I just wanted to make a comment about the sort of the rule out TB hysteria. I have a challenge with. I mean, we do TB testing all the time, and we don't tell people to isolate because we just give them sputum bottles and send them on their way. how do we actually get AFB without, we can't get AFB in a dialysis unit without putting somebody on isolation, which seems unfortunate because in some ways we're going to be hedging our interpretation saying, well, you probably don't need to isolate, and well, don't do AFB unless you're really worried, when really if we just did some sputum tests, we would be extra reassured, but we don't because isolating them is a pain in the backside. And so it's a little bit of a vicious circle.
Yeah, I mean, we can, we send people home with, oh, it looks like you might have TB. Here's some bottles. Come back in a couple weeks. We do that all the time. I'm not saying that we're cavalier about it, but just keep in mind.
That sounds like it's education of nurses, right? Like the nursing staff needs to understand that AFB doesn't equal isolation.
Yeah.
Because that's not how we and they were taught.
Yeah, totally.
Right? And so that's an education program that has to be put in place so that you don't have to say the wrong thing on the, not get a test because you're afraid of what the consequence of asking for the test is. That seems to me a bit backwards. But
just to circle back to the original question from the person in Ireland. So yes, I agree. Pre-dialysis chronic kidney disease, we should screen. We have some evidence that it's cost-effective, specifically in people born in high-incidence countries. We published on that recently. I think we should do it. The question is how.
One suggestion to me, because his audio doesn't work, was that perhaps at the time of modality selection, when people are we have a process by which we systematically ask and get them to choose. When they've chosen their modality, might be an appropriate time to screen, treat, and it might actually reduce the. Anyways, it's a question. We could talk about it.
It's a great idea.
As a thought, but
the thing that we want to avoid is screen rescreen, meaning they get screened 3 months before when they're getting their fistula or whatever, and then they start dialysis, and then they get screened again because it's just the protocol.
We could have a system. I think we have a linked system, so we should be able to do. We wouldn't just say, okay, as of tomorrow, we're doing all of this, but it's something that we can talk about with the KCC, PD, and the whole program, actually, the constellation, see what kind of thing would actually work. And with respect to resources, I think it behooves us as a province and the PHSA for us to figure out how we're going to resource this, especially if the data is as strong. And you can do a number needed to treat, and you can say what's the total cost of treating a treated TB case. I can't remember the numbers, you showed them to me once, but it's a very cost-effective thing to screen TB to avoid a case. So if this province wants to do what it says it wants to do, which is be leaders in innovative evidence-based care, well then you have to fund it.
Yeah.
So we can talk about how to do
And we're all PHSA agencies, which is nice.
Sunit had a question.
Oh.
Hi. Sorry, it's not so much a question. It's just going back to the communication tool. I think, as you mentioned, the dialysis patients have a lot of comorbidities. They often have a lot of consultants coming back. And one of the things that's difficult is when people put this patient should have this or something, but it's not clear actually who's going to do it. And I think that's where things fall through, a patient who said, oh, this patient should have, an annual ultrasound to screen for their HCC because they are chronic hepatitis B, which is a huge problem as well. But who is doing that? And so as part of the communication, it should be clear that if, for example, my feeling is that if you were seeing a patient right there who had some really serious chest x-ray abnormalities, that isn't just a form that goes to a dialysis unit. It's like me seeing a patient with a potassium 7.1. I don't go, oh, well, maybe next week I'll pick up some medications. There's some patients that require actually a direct physician-to-physician communication or action right there and not just a recommendation on a form to go back to somebody. Especially with nowadays, as we all know, we have computers and everything, but there's delays in receiving information. Sometimes we have received a report 2 months later. And, so...
Just to be clear, though, we don't see the patients in clinic. We have a physician going through, literally, they go through a stack of dialysis screening forms. We all kind of work on salary. We kind of come and go, and we grab the stack one day, and we just burn through them and try and make the best recommendations we can. That's how we do it. And we do it for the entire province that way. So I agree, it's not optimal. Sorry, Tori, you did have a comment.
Or I was wondering whether, just thinking back to the hysteria around collecting sputums from an infection control perspective, maybe it's an argument to do gene expert testing in spot sputum testing in the units. So when we suggest to do AFB ×3, just do a gene expert and be done with it, right?
Yeah.
Comes back in a couple of hours. You don't need to isolate for those 2 hours.
Yeah. Sorry, for those who don't know what Gene Expert is, it's a test that was originally rolled out years ago by the Gates Foundation, which has really changed TB globally. All it is it's a PCR of a sputum. You spit in a cup, put it in a machine. 2 hours later, it tells you if it's TB or not. It's very easy for low-income countries to use. We actually had it for a while, but because we have in-house PCR at the BC CDC, we don't use it. But I know, for example, St. Paul's has it for MRSA testing. So we could, each bottle takes, it's $10 or something like that. Maybe it's $30. I don't know. It's around there. It changes year to year. But we could think about doing that, yeah.
Jay, hi.
Yeah, good.
Hi, it's Bev. When we started the screening program at St. Paul's in the hemodialysis unit, we were told not to screen everyone just because it would overload the whole lab. So I believe there's still patients who have not been screened. Do you recommend that we screen the entire hemodialysis patients, those patients that were left over and haven't been screened?
That's a good question. I don't know. I mean, screening uptake, if we go to the very bottom.
Actually prioritized, and we said everybody initiating dialysis.
Yeah,
that's the protocol.
but not the legacy.
So we didn't do the
people.
legacy because we said that if they were on the transplant list, they would have been screened for that. And so I think and that within 3 years, everybody would, given mortality and everything.
And we can see that it's probably 90% of people have been screened in VCH. I don't know about St. Paul's in particular. What I would say, and this is off the cuff and not a policy, so please don't interpret this as a policy, but for those legacy people, if they've been out more than a year, they're still at risk. They're at lower risk. So I might consider pick and choosing depending on their epidemiological profile. So if you're born in a high incidence country, I would probably do an IGRA on that person. But if the person is, born in Canada, non-Indigenous, has absolutely zero risk factors, no exposures, no drug use, nothing, then and they're 3 or 4 years out of starting dialysis, I don't really see a reason to screen them unless they're going for a transplant. That's what I would recommend off the cuff. Don't interpret that as a policy, but it's a reasonable way to approach it, I think, taking the highest risk people. I hope that helps.
Anywhere else? I can't see all the different sites. I know VIHA had problems with their room, so that's why they're on WebEx. If you have more questions, John, you don't have to text me. We can unmute you.
I have a quick question.
Great.
Hi, Jay. It's Miriam. Thanks for the talk. I'm just wondering what your messaging to our dialysis patients is when you do see them with a positive test and have the discussion about initiating therapy. I say this because there are occasions when patients return to the dialysis unit and say, I saw somebody and they told me that I need something and I said no. And that's sort of where it ends with them. And, it's sort of on us to really make them understand that, listen, if you don't get this, it might have implications for your transplant. You may develop TB and, albeit these are dialysis patients who are uremic and have poor understanding of many of their issues. But I'm just wondering, what is the messaging that you give them? Do you tell them if you take this, you're not going to have active TB, or is it sort of if you take this, it might reduce TB? How do you sort of word it?
So everybody's different, right? So I can say what I do, Tori can say what she does. I can tell you, I can't say what Kevin Elwood says. Everybody has a different approach and communicating this. Generally speaking, we have very good uptake. So to start with, I come down very hard and say, listen, you're at very high risk. You're up to 25 times the risk of the general population. You have, if you get TB, I know in dialysis that you're at high risk of mortality. This could be a lethal infection for you, including meningitis. And so I just paint this picture that's true of a person who gets TB in dialysis is extremely dangerous. And then I say, if you take this therapy, we know that it's at least a 90% reduction, if not more, and your risk basically goes to zero. And I always say basically goes to zero to people to make sure they understand. I tell them about the adverse events and say that it's possible that they will develop hepatotoxicity, but generally speaking, 80% of people complete therapy. Hospitalizations, more than 99% of people don't have any significant adverse events requiring hospitalization, and that's sort of how I go through. They have to be informed of all the risks. Certainly there's a public health benefit, but there's an individual benefit to this too. And so I don't think it's a hard sell, but as we kind of know in medicine, I think older physicians tend to come down less hard. I know my approach has been much more aggressive. I've put 80-year-olds on dialysis, on TB therapy, and my colleagues kind of raise their eyebrows. So everybody's a little bit different, and I can't speak for my colleagues. I don't know, Tori, if you have any thoughts on that.
No, the only thing I would add is that we do say that it's their choice, right? Like, so LTBI therapy is not mandatory. It's different than active TB treatment. So they do have the option of saying no, but they have to understand the risk-benefit of making that decision. The only thing that I do say to them is that, clearly, from a messaging perspective, sometimes they need a little bit of time to chew on it before they want to start treatment. And I offer them the chance to go back to talk to their family doctor, to talk to their dialysis provider, whoever it is that helps them make their treatment decisions, and then come back to the clinic and have a go at it again. But it's, so it's non-compulsory. There is some patient autonomy in decision-making, but generally most of the people that come into the unit, when I tell them what the side effects of the medication are, they say, oh, I have all that anyways. And so they're like, whatever, what's 9 months of isoniazid on top of how terrible I feel already? So it actually has not, for me, I don't think I've had many, if any, refusals, but I do let people go chew on it and come back.
Questions is the same ways you have a virtual clinic with NPs and other people speaking to the patients who know them best. It may be that with our complex dialysis patients, that a conversation with the nurses and the physicians and some kind of distributed communication, because you go to see a stranger, with all due respect, once in a clinic that you've never been to, and you never really go back there again. Not the same kind of obligation as the dialysis unit. So, or you guys come and come and see them in our dialysis clinics, and that might actually be, there's just different ways, and we can look at different models, but it sounds, just to conclude, it sounds like A, it's been an effective program, B, it needs some more resourcing. But if we're going to make it sustainable, then I think probably now is where all of the people involved in the clinical pathways, maybe now is a good time to sit down and work out how do we actually reduce the communication barriers. Like I was just finding out from Claire, there's 120 days after the test as a report comes to the dialysis unit, because it gets lost in, and it's no one's fault. It's no one's fault. Yes,
it is. This is our EMR.
Okay, that's your EMR. But so it's only going to get worse because soon there will be EMRs that don't talk to each other. So it's going to be even harder. And so another reason I think that we need to understand what we can do with what we've got, and then what are the processes that go in place that actually improve that kind of communication and touch base. And maybe it's a huddle once a month, or these are the positive patients and these are what needs to be, there's lots of different ways to do it. It's not always electronic. That's not always the solution to everything. It's less time. But
no, I totally agree. We like having more and more iterative approach where every quarter, 6 months we meet. How do we adjust this algorithm?
And there's a provincial hemodialysis and provincial PD program and the KCC group, and maybe that's so interested people from those three committees plus yourselves sit down and sort of work out some, care maps really, or process maps, because we haven't done that part since we implemented the program. Totally. But no, I think it's been super interesting and really great to see the results of everything, and I very much appreciate it. And I think we'll stay tuned and look forward. And I think once there's a publication, that's also easier for us to take to PHSA. Yeah. Right? Yeah, absolutely. Yeah. No, it's way okay. So the whole world thinks that we're doing this, except you're not funding it. Good luck with that.
Yeah. No, agree.
Anyways,
thanks everyone for having us.
Thanks, both of you.
And